Okay, let's focus on the last topic of the day, which is imaging of the lung. Let's talk about different types of lung imaging. Maybe it's ventilation and perfusion imaging. Maybe it's CT scan. Maybe it's chest X-ray.
Chest X-rays, CT scans, and ventilation perfusion VQ scans are key lung imaging methods. X-rays show basic lung structure, catching pneumonia or masses. CT scans give detailed 3D views, ideal for detecting tumors or clots. VQ scans map air and blood flow, mainly used for pulmonary embolism diagnosis. Want to dive into how these work or their specific uses?
Let's start with chest X-rays. So we've got certain things such as rotation, exposure, coverage when thinking about how to assess a chest X-ray. But how do we assess the chest X-ray?
To assess a chest X-ray, you check rotation by ensuring the clavicles and spine are symmetrical. Confirm exposure by verifying clear visibility of lung fields and bones, and evaluate coverage to see if the entire chest, including lung apices and diaphragms, is included. Then, systematically review the trachea, heart size, lung fields for abnormal opacities or masses, and bones for fractures, looking for issues like pneumonia or pneumothorax. Want to dig into specific findings or other imaging like CT?
I want to ask about the radiography. So what are the strengths and weaknesses and what do we mean? What is included in the word radiography?
Radiography refers to imaging techniques using X-rays to visualize internal body structures, like chest X-rays for lungs or bones. Strengths include quick, low-cost imaging and wide availability, ideal for detecting pneumonia or fractures. Weaknesses are limited detail compared to CT and radiation exposure risk. Want to compare radiography to CT or explore specific chest X-ray findings?
So strength, tell me again what includes radiography. So strength, great spatial resolution, cheap, available, easy interpretation. Weaknesses, ionizing radiation, projectional.
Radiography includes imaging techniques using X-rays, like chest X-rays or bone scans, to capture 2D images of internal structures. Strengths are high spatial resolution for clear bone and lung outlines, low cost, wide availability, and relatively easy interpretation. Weaknesses include ionizing radiation exposure and 2D projection limitations, which can obscure overlapping structures compared to 3D imaging like CT. Want to dive into specific chest X-ray uses or compare to other lung imaging?
Let's talk about let's talk about CT scan strengths and weaknesses and compare it with radiography. Do they both have ionizing radiation or no?
Both CT scans and radiography use ionizing radiation, but CT delivers a higher dose due to multiple X-ray beams creating detailed 3D images. CT's strengths are superior detail for detecting tumors, clots, or lung.
Is CT just a bunch of X-rays basically? Is it exactly the same thing, just in a bunch?
Yeah, you're kind of on the right track. CT scans do use X-rays, but it's not just a bunch of them thrown together. A CT scan takes multiple X-ray images from different angles around your body. Then, a computer stitches them into detailed 3D or cross-sectional views, giving way more info than a single 2D X-ray. Regular radiography, like a chest X-ray, uses one X-ray beam for a flat image, so it's simpler, cheaper, and shows less detail, while CT's strength is picking up fine structures like tumors or blood clots, but it zaps you with more radiation. Want me to break down specific lung findings on CT versus X-ray, or stick with something else?
No, this is good. This is a nice explanation. Okay, let's say we're imaging the lungs. So let's talk a bit about the structure and function of the lungs. So we have a primary, you go for it. And I want you to go and include primary and secondary pulmonary lobules in your answer. and alveoli.
The lungs are spongy organs designed for gas exchange, with airways, bronchi, branching into smaller bronchioles and alveoli where oxygen enters the blood and carbon dioxide leaves. The primary pulmonary lobule is a functional unit, centered around a bronchiole, alveoli, and capillaries, while the secondary pulmonary lobule, visible on CT, is a larger cluster of these units, surrounded by septa containing veins and lymphatics, crucial for assessing diseases like emphysema or fibrosis. Want to tie this to specific CT findings or compare imaging techniques for lung structure?
I still don't understand these primary and secondary pulmonary lobules, what they are.
All right, let's simplify. The primary pulmonary lobule is the tiniest functional unit in the lung, made of a small airway, terminal bronchiole, the alveoli, tiny air sacs where gas exchange happens, and blood vessels for oxygen and carbon dioxide swap. The secondary pulmonary lobule is a bigger group of these primary units, wrapped by connective tissue septa that hold veins and lymphatics, visible on CT scans and used to spot patterns in diseases like infections or scarring. Want me to explain how these show up on imaging, or focus on a specific lung disease?
Can you hear the water bottle, guys? Okay. Well, I want us to understand kind of the different structures. So, okay, I got that part. What about other structures, such as the pore of Kohn, or the terminal respiratory unit, or the asinus, or respiratory bronchi, terminal bronchi, connective tissue septum? Can you explain these two?
All right, let's break down these lung structures simply. The pores of Kohn are tiny openings in alveoli walls, letting air move between adjacent alveoli to balance pressure, visible in detailed imaging like CT when studying diseases like emphysema. The terminal respiratory unit, or a sinus, is a functional unit past the terminal bronchiole, including respiratory bronchioles, alveolar ducts, and alveoli, where gas exchange starts. It's key for understanding diseases like pneumonia on imaging. Respiratory bronchioles are airways just beyond terminal bronchioles, with some alveoli budding off, marking the start of the gas exchanging zone. Terminal bronchioles are the last purely air-conducting tubes, no alveoli, delivering air to respiratory bronchioles. The connective tissue septum is the thin, fibrous layer around secondary pulmonary lobules, holding veins and lymphatics, seen on CT to spot fluid buildup or fibrosis. These structures shape how lungs work and appear on scans like CT, helping diagnose issues like blockages or scarring. Want to link these to specific CT findings?
Well, tell me again one more time about respiratory and terminal bronchi. So what's their difference functionally and structure and location?
Terminal bronchioles are the final airways that only conduct air, located at the end of the bronchial tree with no alveoli and a simple structure of smooth muscle and epithelium to deliver air to the respiratory zone. Respiratory bronchioles come next, located deeper in the lung, and start the gas exchange process, with some alveoli budding off their walls, a thinner structure and less muscle, allowing oxygen and carbon dioxide to begin swapping. Want to connect this to how they appear on CT or explore related lung diseases?
No, that's okay. Okay. So respiratory bronchi are the first ones and then they become terminal.
Actually, it's the other way around. Terminal bronchioles come first in the airway tree, acting as the last tubes that purely conduct air, without gas exchange, located higher up in the lung's branching structure. Respiratory bronchioles follow, deeper down, where the walls start sprouting alveoli, kicking off gas exchange, making them the first part of the respiratory zone. Want me to clarify how this shows up on imaging or move to another?
Booyakasha. Got it. Okay. So, what about, let's talk about radioactive gases like xenon or radioactive aerosol and try to understand ventilation and how we use them.
Radioactive gases like xenon 133 or radioactive aerosols like technetium 99M DTPA are used in ventilation scans to map how air flows through the lungs, often paired with perfusion scans to diagnose issues like pulmonary embolism. You inhale the gas or aerosol, and a gamma camera tracks its distribution, showing areas of poor ventilation. Xenon highlights air trapping, while aerosols reveal airway blockages, though both involve ionizing radiation. Want to compare these to CT for ventilation studies or dive into specific findings?
Okay, and what exactly do we see?
In ventilation scans using radioactive gases like xenon 133 or aerosols like technetium 99M, a gamma camera shows how the tracer spreads in the lungs, revealing normal ventilation as even distribution or abnormal areas as patchy or reduced uptake, indicating blockages or air trapping. When paired with perfusion scans, mismatches like normal ventilation but poor blood flow can pinpoint issues like pulmonary embolism, while matched defects might suggest chronic lung disease. Want to dive into how these scans are interpreted or compare them to other lung imaging?
That's good. Okay. Question now. How could we produce a steady state image of lung blood flow?
To produce a steady state image of lung blood flow, you typically use a perfusion scan with a radioactive tracer, like technetium 99M labeled macroaggregated albumin, MAA, injected intravenously, which gets trapped in lung capillaries, and a gamma camera captures its distribution, showing blood flow patterns. Continuous imaging during steady breathing, often paired with ventilation scans, ensures a stable view of perfusion, highlighting defects like those in pulmonary embolism. Want to dive into the tech details or compare this to CT angiography?
Yeah,
All right.
Let's do that.
Cool. So you want to compare the steady state lung perfusion imaging
Well, I
to
honestly
CT
didn't
and
understand what it is, to be honest.
no worries. You don't need to be a dentist to get this. I'm guessing
No,
you're
I
joking.
didn't say anything about dentists. I said I don't understand what the previous answer to the question was either.
My bad. I must have misheard or got wires crossed. Let's clear it up. You asked about producing a steady state image of lung blood flow, and I mentioned perfusion scans with technetium 99M MAA, where a tracer is injected into your veins, gets stuck in lung capillaries, and a gamma camera snaps a picture of where blood's flowing, showing if it's even or spotty. If that's still unclear, can you pinpoint what's confusing, like the tracer, the camera,
That's all good.
or how
Okay. And what patient posture would achieve the most uniform distribution of particles through the lungs?
The supine position, lying flat on your back, achieves the most uniform distribution of particles, like radioactive aerosols or tracers in lung ventilation or perfusion scans, as gravity evenly spreads them across both lungs. Standing or sitting can cause more particles to settle in lower lobes, skewing the image. Want to dive into how this affects
Why
scan results?
supine?
Lying supine, flat on your back, lets gravity distribute radioactive particles, like those in ventilation or perfusion scans, evenly across both lungs, minimizing pooling in the lower lobes. This ensures a uniform spread, unlike standing or sitting, where gravity pulls particles downward, skewing the scan toward the lung bases. Want to explore how this impacts specific lung conditions or another imaging topic?
Well, I want to touch a bit on lung pathologies and how we can recognize them through imaging.
Lung pathologies show distinct patterns on imaging, like chest x rays or CT scans. For example, pneumonia appears as patchy opacities or consolidation on x ray, while CT might reveal ground glass opacities. Pulmonary embolism shows filling defects on CT angiography, and emphysema looks like overinflated, dark lung areas with bully on CT. Want to focus on a specific pathology or how these are spotted on different imaging types?
Yeah. For instance, how do we see consolidation?
Consolidation on a chest x ray shows up as white, opaque areas where air in the alveoli is replaced by fluid, pus, or blood, often from pneumonia, obscuring lung markings. On a CT scan, it appears as solid, homogeneous patches, sometimes with an air bronchogram, air filled bronchi visible against the opaque lung, pinpointing infections or hemorrhage. Want to dive into other lung pathology signs or focus on consolidation causes?
Yes, give me more examples.
All right, more lung pathology signs on imaging. Pneumothorax shows a clear, air-filled pleural space with lung collapse on chest x-ray, often with a sharp lung edge. Pulmonary edema from heart failure appears as diffuse, fluffy opacities or bat wing patterns on x-ray and ground glass opacities with septal thickening on CT. Lung cancer might present as a solitary nodule or mass on x-ray, with CT showing irregular borders or lymph node spread. Want to zoom in on one of these or explore how they're diagnosed further?
Um, yeah, let's do a closure. So summarize everything about the lung imaging.
Lung imaging, like chest x-rays, CT scans, and ventilation perfusion scans, helps diagnose pathologies by showing structural and functional issues. X-rays catch basic problems like pneumonia's consolidation, CT provides detailed views of tumors or emphysema, and VQ scans with radioactive tracers like xenon map air and blood flow for issues like pulmonary embolism. Want to wrap up with a quick recap of anemia or exercise 2, or call it a day here?
Yeah, let's call this episode a day. Thank you.